Hi, welcome to our lecture on the skeletal system. This will go kind of hand in hand with everything we talk about in the muscular system to talk about how we move, how our bodies are supported, and everything along those lines. Our objectives for the lecture are right here. As always, if you are comfortable with these, you should do very nicely on the quiz that we have over this. So your basic skeleton, we're going to look at how different ways that we can divide the skeleton. You do not need to know all the bones of the skeleton, which is nice. If this was a full-blown anatomy class, we would be going over the entire skeleton, all the bones, all the bits and pieces of the bones. The skeleton can be divided into two halves, your axial skeleton and your appendicular skeleton. What does this word axial mean? If we have a globe and I say we're looking at the axis of a globe, what is the axis of a globe? It's the little line, the little stick that runs down it, that it spins around. That's what the axis of a globe is. Or think about the axle on your car, the metal rod that your two wheels are stuck to on either side of it. That's kind of the same idea behind calling your spine your axial skeleton. This is your skull, your spinal column, and your thorax, and this includes your ribs, your sternum or your breastbone. Your appendicular skeleton is everything else then. Your shoulder girdle, which includes the clavicle and the scapula. The arms, the bones of the arms, the bones of the hands, the pelvic girdle, which is all of the bones of the pelvis that we'll look at in a little bit, and then the bones of your legs and your feet. So looking more detailed at the axial skeleton, this is made up of your skull. You have a whole bunch of bones in your skull that are all fused together. 8 bones of the cranium, which is kind of the top of the skull, 14 bones in the face. We'll look at that in a little more detail. And then all of the vertebrae in your spine, cervical, thoracic, lumbar, sacral, and coccygeal. So looking at your skull, when I say the cranium of your skull, I mean this part right here, the big part of the skull. And you have 4 bones on either side, 8 bones total. You have 2 frontal bones, which are these guys up here in the front, 2 parietal bones, 2 occipital bones down here in the very back, and 2 temporal bones. Those are the bones of the cranium. And then we have a bunch of bones of the face, 7 bones on each side, so 14 bones total. Some of them you can't see, some of them, like your ethmoid bone, are actually inside your sinuses, inside your nose. Some of them are back behind your eyes, like your lacrimal bones. Where the bones of your skull come together, these little wavy lines right here, these are called sutures. The bones of your skull come together and fuse together. If you have ever been around a newborn baby, you know that their skulls are kind of squishy when they first show up. They're very soft and they have a big soft spot in the top of their head. And that's because the bones of the skull haven't completely grown and developed, and they haven't finished fusing together. Here are the bones of the vertebral column. The bones in your neck are called cervical vertebrae. And usually when I'm talking with my students, when we talk about cervical stuff, their mind goes one place. You think about, oh, cervix, isn't that down in the uterus? And yes, there is a cervix in the uterus, but cervix, the word cervix, just means neck. So your cervical vertebrae are the vertebrae found in your neck. The cervix of the uterus, see, this is not going to be a pretty uterus at all, is like the neck of the uterus. Right? Think of like the neck of a bottle, for example. So that's why we have 2 cervices in the body, if you're female. So cervical vertebrae in your neck, thoracic vertebrae are the vertebrae of the upper chest, and these all have a rib associated with them. You have 12 thoracic vertebrae, and you have 12 ribs coming off of those vertebrae. The bones of the lower back are your lumbar vertebrae. Your sacral vertebrae, there are 4 or 5 of them that are all fused together. They sit in the very bottom, kind of right above your butt, in between your hip bones. And then your coccygeal vertebrae are your tailbone. So your thorax consists of your 12 ribs and your sternum, and all of that is part of your axial skeleton. So appendicular skeleton then, this is everything that's attached to your axial skeleton. We can start with the shoulder girdle, which is, you can see here, the clavicle, this bone up here, and then the scapula or your shoulder blade. The clavicle you sometimes hear called your collar bone. These two bones together help to hold your arm bones onto your body. Looking at the arm bones, we have the humerus, which is the bone of your upper arm. And then in the lower arm, you have two bones. You have the radius and the ulna. And the easiest way to remember them is that the ulna is bigger at the top and smaller at the bottom. The radius is smaller at the top and bigger at the bottom. The radius also runs along the thumb. The ulna runs along the pinky. If you have your arms out in anatomical position, hopefully you remember your anatomical position. Going down from the radius and the ulna now, we find the carpal bones. Carpal means wrist. So these are a series of 8 tiny little bones all packed together in your wrist, right here. The bones of your hand are your metacarpals. So take a minute, run your fingers over the back of your hand. The bones that you feel there are your metacarpals. And then the bones of your fingers are your phalanges. Your phalanges are both your fingers and your toes. One is called a phalanx. So poke somebody with a phalanx and see what that does. Looking at the pelvis is formed of 2 bones that fuse together. And those 2 bones are formed of 3 fused bones. So there's a lot of bones in the pelvis: the ilium, the ischium, and the pubis. The ilium is this big, probably the biggest bone of the pelvis, big curved wings of the ilium right here. And actually we call them the wings, or the ala of the ilium. This is our, if you put your hands on your hips, you have your hands on your ilium, specifically on your iliac crest, this top part of the ilium here. If you ever have a bone marrow transplant, you give or receive a bone marrow transplant, sometimes you'll get bone marrow taken out of the ilium here because it's easy to access. It's right there in the lower back, and it's a really big bone. So that's the ilium. The ischium is this little bone in the back here. I had a class that called it your squishy ishy. This is your sitting on bone, your butt bone, probably the bone you're sitting on right now. And then the pubis is this bone right here that covers kind of the front of the pelvis. It even goes to the back a little bit. So those are the 3 bones that make up each half of the pelvis. The pelvis is not fused together. Rather, we see this little band of cartilage right here called the pubic symphysis that holds each half of the pubis together. This is really important. Why would we want a little band of cartilage right there? Why not just fuse the whole thing together, have one whole great big bone, and call it good? Why stick a little band of cartilage in there instead? And the reason for that is, for those of you who have ever had kids, this little band of cartilage allows the pelvis to stretch when that baby is passing down through the pelvic canal. To get even more fun when we talk about the pubic symphysis, if you have a dystocia where the baby is coming out breech, they're coming out feet first, butt first, and you're having issues getting the head through the pelvic canal, in a very extreme dystocia, you might go in and actually cut that pubic symphysis, cut that little band of cartilage to open up the pelvis and allow the baby to pass through the pelvic canal. Obviously, this is an extreme kind of last-minute resort. You don't do this a lot, but it is done in emergencies. The pubic arch, what is being measured right down here, is how we determine when you're doing forensics whether or not your patient is male or female. If you come across a skeleton in a field and the forensics are out there trying to figure out, was this a man or a woman? A male will have a more narrow pubic arch. Woman will have a broader pubic arch because you need to fit, again, a baby through that pelvic outlet. Looking at the bones of the leg, the setup is actually kind of similar to the bones of the arm. The upper bone of the leg, your thigh bone, is your femur. This is the biggest bone in the body, the strongest bone in the body, the hardest bone in the body to break. Your patella is your kneecap. And then you have two bones in your lower leg. The bigger one is the tibia. I always remembered tibia because it's shaped like a T. It's got a flat top and then it just goes straight down. This little guy on the outside here is your fibula. If you reach down on the outside of your ankle, feel that little bone on the outside of your ankle, that is the bottom of your fibula. And then your ankle bones are called your tarsals. And then just like your hand, the bones of your foot are called your metatarsals. So run your fingers, your hands over the top of your foot. Those are your metatarsals. And then again, fingers and toes are your phalanges. These are some combining forms that talk about bones and joints and the skeleton. I'm not going to go over all of them, again, because you don't want to listen to me read all those off. There is one that I'll point out. This guy right here, myelo. Myelo has a double meaning. It refers to your bone marrow, but it can also refer to your spinal cord. So keep that in mind. Right now, during this chapter, when we're talking about anything with myelo, we're going to be talking about bone marrow. But in a few weeks, when we get to the nervous system, we'll be talking about the spinal cord as well. There are a bunch of combining forms that refer to vertebrae or to the spine. Both spondylo and vertebro refer to your vertebrae. Rachio, that's not rachi, that's rachio, also refers to the spine. Costo, C-O-S-T-O, refers to your ribs. I had a class that remembered this because they remembered that if you want to get a bunch of ribs, you go to Costco to get the giant pack of ribs. So, you know, whatever works for you. All right, bones start forming at birth. They're formed from cartilage. Cartilage is not as hard as bone. It's a lot more flexible. And this is good because you have to fit that baby, again, through the pelvic canal. You'll see a lot of reference to that as we talk about bones. Once you're born, your bones begin to ossify, so they start to turn into bone. You start to lay down calcium on those bones, and that continues up until you're, 18 or so, maybe 17. There are three types of bone cells that you find in bone: osteoblasts, osteocytes, and osteoclasts. Osteoblasts, this suffix blast you've seen before when we talked about cells. Blast is an immature cell. I always tell my students, remember B for blast, B for baby cell. It's a little baby cell that hasn't matured yet. It's not completely developed. Osteocytes are mature bone cells. They maintain the bone. They keep it supported. They help to bring nutrients to the bone tissue. And then osteoclasts destroy bone. They break down bone. And I always remember the difference between a blast and a clast and a cyte. Blasts are baby cells, and then clasts, I always thought of a cat, an osteocat, because cats are always like destroying things and pushing things off of counters, if you've been around a cat. Why on earth would we want a cell that breaks down bone tissue? Why do we want to break down, isn't that important? We don't want to be a little sack of jelly, a little amoeba flailing around on the floor. Why would we want cells that break down our bone tissue? This sounds terrifying. And the reason why we have little osteoclasts to break down bone tissue is if we have any kind of damage to the bone, trauma to the bone, maybe you have a break to the bone, those osteoclasts are going to go in there and help to heal that bone. They will smooth out that break, make it nice and neat, and then allow the bone to lay down new layers of bone. You also see osteoclasts in work when you need more calcium in your blood. This is where we get our blood calcium, is from our bones. Resorption is this process of breaking down bone so you can absorb that calcium from the bone back into your bloodstream. We'll look at the makeup now of a bone, specifically a long bone. A long bone is called a long bone, not necessarily because it's long. Some long bones are very short. A long bone is a long bone because it is longer than it is wide. The shaft of a long bone, the long middle section of the long bone, is called the diaphysis. Dia, that prefix dia, means through. I always tell my students, if you go to DIA, you go to the airport DIA, nobody goes to DIA to just like hang out at the airport. I mean, maybe you do. Maybe you're looking for the aliens underground or something. But most people don't go to DIA to just chill at the airport. You go to DIA because you're going to go through the airport to go somewhere else, hopefully somewhere cool. None of us are going anywhere right now, but still. So the diaphysis is the shaft, the through portion of the bone. The inside of the diaphysis is hollow, and it's filled with yellow bone marrow. Yellow bone marrow is mostly fat. It's there for support, it's there for protection, it's there to cushion the bone or act as kind of a shock absorber. Either end of the bone is the epiphysis, and we've seen this prefix epi before, right? Epi means upon or above or on top. So the epiphysis is either end of the bone. The epiphysis is not hollow, it's just made of this very, very spongy bone with lots of tiny, tiny holes in it. And this has red bone marrow. So we have two types of bone marrow, red bone marrow and yellow bone marrow. Red bone marrow is where you make stem cells that will eventually become your blood cells. This is where your blood cells are made. This is why we talk about doing a bone marrow transplant for someone who maybe, say, has leukemia, has some issues with their blood cells. Each epiphysis is covered by a little thin layer of cartilage. That cartilage serves as a shock absorber to keep the bone from rubbing against other bone and to absorb any pressure on the bone. In between the diaphysis and the epiphysis is the metaphysis. Meta means middle, so it's right in between, in the middle. And in the metaphysis we find what's called the epiphyseal plate, or the growth region, or sometimes you'll hear it called the growth plate. And this is the place from where the bone grows and develops. And we'll look at a picture of that in a minute. The whole bone is covered in this thin little fibrous connective tissue called periosteum. Peri means around or surrounding. Lots of term words in this part of the lecture. So the periosteum is just surrounding the bone. This is where we develop new bone cells. The periosteum brings nutrients and oxygen to the bone and keeps those cells nice and healthy. So here's our long bone right here. You can see on either end of the bone, this would be the epiphysis on either end. Our shaft of the bone, this long section right here, and you can see the diaphysis is hollow. Here's our medullary cavity full of yellow bone marrow and also with an artery and a vein running through it. You can see on the epiphysis up here, the bone tissue isn't hollow, it's just full of tiny little holes. It looks like a little sponge. And in all of those tiny little holes, that's where we find our red bone marrow. The metaphysis of the bone would be kind of right here, where we would expect to see growth plates right there and right there. So if we were to go into to Children's Hospital and you got an x-ray, a radiograph from some kid there, this is their ankle. You see the big bone on the left is the tibia, and then the little bone on the right here, this is the fibula. and we were to take this radiograph, stick it up in the light, and say, look, here are the bones of your ankle. What does it look like happened to these bones? What does it look like happened right here? It looks like our patient broke their tibia and their fibula. It looks like they sheared the tibia and the fibula right off. Looks kind of terrifying. In reality, that's not what happened. These are not broken. What you're looking at there is the growth plate or the epiphyseal plate. The growth plate, remember, is mostly cartilage, and cartilage doesn't really show up on an x-ray. So that's why it looks like there's a giant crack in both of those bones. It's not a crack, it's just, again, cartilage that doesn't show up very well. We see the same thing here in these two x-rays of hands. One is a younger teenager, he's 14, one is 16 years old. You can see in the 14-year-old, all these tiny little bones down here, these are all epiphyseal plates right here. These are all places from where those bones of the hand are growing. These here and here, you see tiny little ones up here. If we look at our older patient, you can see that the epiphyseal plates have started to fuse. You can still see there's a bit of a line where those plates are starting to come together, especially these ones right here on the first phalanx. But it doesn't look like he has a bunch of tiny little bones just kind of floating around his hand like his neighbor does. This is a good way of determining whether or not your patient is done growing. Take them in, x-ray them, see if they still have epiphyseal plates in their bones. If they do, they're not done growing yet. Joints are also called articulations, and we have different names for different types of joints. The types of joints are named for how much movement you get in between the bones. An immovable joint is a suture, and we looked at this a little earlier when we looked at the bones of the skull. Remember those little wavy lines that are holding those bones together? Sutures are immobile. You should not have any movement in your skull, in between the bones of your skull. If you do, please go see your doctor. A symphysis is a joint with a little bit of mobility. We looked at a symphysis when we looked at the pubic symphysis in between the two pubic bones. This is held together by a little piece of cartilage. Your spine is also made up of a bunch of symphyses. You have little cartilaginous discs in between each vertebrae. And then the joint that you usually think of when you think of a joint, at least outside of Colorado, is a synovial joint, also called a diarthrosis. This is a freely movable joint. This would be something like your fingers, your elbow, your shoulder. You have this wide range of motion, and this is because this is a freely moving joint. Synovial joints are held in little capsules called synovial capsules that make fluid called synovial fluid. And this synovial fluid serves to lubricate that joint and protect the bones within the joint. Within the joint, you'll find ligaments. Ligaments connect bones to bones. So if you have ever had a friend, say, who has torn their ACL or torn their meniscus, or if you have torn your ACL or torn your meniscus, you have torn a ligament there. That's what ACL stands for, your anterior collateral ligament. Tendons attach muscle to bone. They are how muscle holds onto bone and makes bone move. I would know the difference between a tendon and a ligament for the quiz on Monday. These are a bunch of term words here. Again, we're not going to go over all of them just because you don't want to listen to me read them all off, but do come back and revisit them so that you're familiar with these terms for your quiz. And these will also be very helpful for the homework. So let's look at some clinical stuff associated with the skeleton. If you study the skeleton, diseases of the skeleton, injuries to the skeleton, that's called orthopedics. Orthopedics is the medical field that the doctors go into who really like playing with like hammers and saws and working on stuff in their tool shed on the weekend, because orthopedic surgery tends to be a little, not gruesome. You're just using a lot of very big instruments, and sometimes it can be a little intimidating. Lots of saws, lots of hammers, lots of drills, things like that. Things that you don't want to see in an operating room. Means that we use to detect issues with the skeleton. Radiographs obviously are the first one. Send your patient in for an X-ray, CT or MRI, especially if we're looking at the possibility of issues with soft tissue. And then changes in levels of calcium and phosphate. Those are the two main chemicals that make up your bones. And if you see issues with calcium and phosphate, that can indicate maybe a metabolic issue with the bones. You can see infection in the bones. It's not especially common, but it does happen. Osteomyelitis is inflammation of the bone. That's our osteo. And then myelo, if you remember, is referring to bone marrow. This is caused by strep or staph bacteria. It's not especially common, but it's very, very painful, can be difficult to treat. Tuberculosis you will sometimes see in the bones. This is not where you think of tuberculosis. When you think of a patient with tuberculosis, you usually think of tuberculosis in usually the lungs. If you read any Charles Dickens novels, there's always some unfortunate character in the corner dying from tuberculosis, or consumption, they used to call it. Poor Tiny Tim. So tuberculosis can spread to the bones. You'll sometimes see it in the long bones, so the bones of the arm and the leg, the wrist and the ankle. If you see it in the spine, which is what we see here, this is called pot disease. And you can see these giant holes in the vertebrae, the lumbar vertebrae here. This is where the mycobacterium has just been eating its way through the bone. You can imagine this is incredibly painful. It also significantly weakens the bones, so that makes your patient more susceptible to fractures in the lumbar vertebrae. Speaking of which, generally speaking, when we talk about clinical stuff with the skeleton, we're thinking about fractures, breaking bones, usually due to some kind of trauma. You fall down and go boom, and you break your arm or your wrist or your leg. Concerns about fractures vary depending on location, which bone is broken. If you break your finger, they're going to take care of you a lot differently than they would if you, say, broke your skull. One of those is a very high-level emergency, one of them is not. The one bone that you really don't want to break, aside from like your skull and your spine, a femur fracture is kind of a high-level emergency as well, because it's a very big bone. It's very hard to break it. So if you actually manage to break your femur, something really bad happened to you, maybe a bad car accident, something like that. Also, remember that the diaphysis of a bone is full of yellow bone marrow, which is just fat. So there's a possibility if you break that femur, now you have a bunch of yellow bone marrow that's out of the bone traveling through the bloodstream, and that can cause an embolism. It can lodge somewhere and block your brain or lungs or heart, and then that's how you get dead. So femur fracture is a pretty high-level emergency. The severity of the break is also of concern. A closed fracture happens when you keep the broken bone inside the body. The skin's not broken. In an open fracture, you've got like bone sticking out of your patient's skin. It's pretty bad. The different types of fractures that you might see. We talked about our closed and open fractures here. Closed is in the skin, open is sticking out of the skin. A Colles fracture is found in the head of the radius. You see this a lot when someone falls and tries to catch themselves on their wrist, and that results in that break in the radius. A comminuted fracture, what we see right here, is a fracture that breaks into lots of tiny little pieces. Now, lots of pieces. It could be a bunch of tiny little pieces. It could be 2 or 3 larger pieces. Compression fractures are usually found in the lumbar or the thoracic or the cervical vertebrae. In a compression fracture, the bone of the spine has just become very weak and it kind of crushes in on itself. Compression fractures can be hard to detect. They can be easy to miss. Your patient's talking about, oh, I have a lot of back pain. Well, maybe you pulled a muscle, maybe you sprained something. Usually when you start talking about back pain, people don't start thinking about like compression fractures. So it's not uncommon for a patient with a compression fracture to go unnoticed for a little bit. A green stick fracture occurs when you break a bone only part way. You notice this break didn't go all the way through the bone. The rest of the bone is still in one piece. Impacted fractures tend to happen two places. They tend to happen in the wrist or in the head of the femur. An impaction fracture usually happens when you break a bone and then you force one end of the bone back up into the broken end. And that's what we have here. We have our break, and then this end of the bone gets kind of crammed up into the head of the humerus right there. We'll look at one of these in a little bit. These are also very easy to miss on an x-ray. You tend to see them a lot, like I said, in the hip. Grandma falls down, breaks her hip, stands up, forces those broken ends of the bone into each other. And she's been complaining about hip pain for a while, but when we took her into the ER, they didn't see anything on the x-ray. They said she probably just tweaked it. Again, we'll look at why it's so easy to miss an impacted fracture. An oblique fracture is just a fracture that travels at an angle across the bone. Pot fracture is a very specific kind of fracture that occurs in the ankle. You see this sometimes in football players, soccer players, hockey players. It occurs when you have a force come at your patient from both sides and their ankle rolls back and forth, and that causes that break in the tibia and in the fibula. Spiral fracture is a twisted pattern, this twisted spiral break going down the bone. And then a transverse fracture occurs when you break a bone and then it starts to get dislocated and move, so your break doesn't line up anymore. Okay, so now that you are familiar with all of our different fracture types, let's see what kind of orthopedic surgeons you all are. So our first fracture is these two radiographs right here. One's from the front, one's from the side. This is our tibia right here, fibula right here. Here's our tibia. Fibula is kind of right here. We're looking from the side. What kind of fracture do you think it is? Usually when we do this in class, my students are all, oh, it's open, it's open. They probably have bones sticking out of their leg. They might. I mean, the way that this is kind of jutting out here, that's quite possible. But because we can't see what their leg looks like, let's just stick with what type of fracture is it. So if we look at our fracture, we've got, it looks like one piece here, there's a piece here, there's a piece here, there's a piece here. We can see kind of lots of little pieces in our radiograph here. Quality is not super good. This is a comminuted fracture. A broken bone that's broken up into lots of tiny little pieces. How about on the other side of the screen? We have these two fractures, or two radiographs of the same fracture. We're looking at the radius right here. Here's our radius, here's our ulna. Again, radius here and ulna. And look at where the arrow is pointing, this little break line right here. So a lot of the time, my students get really excited, like, oh, that's the impacted fracture. And it looks kind of similar to what an impacted fracture might look like. But if we look over here, especially on this one, we see that the break doesn't quite go all the way through the bone. We go to about here, and then the rest of the bone looks good. It's not broken. So this would be our green stick fracture. We broke half of the bone, but not the whole thing. And then take a look at our patient's wrist up here. Take a look at this thing. What do we know about our patient? The age of our patient. They're pretty young, probably, I don't know, 5, 6, 7 years old. Okay, our bones on the left, all 4 of these are looking at one break, A, B, C, and D. Again, we're in the wrist. Here is our radius, here is our ulna, and it doesn't really look like there's a break there. I mean, look at where our little arrow is pointing right here. Like, nothing's broken. We don't see any gap. What do you think that probably is? That's our impacted fracture. So the bone, the upper part of the radius broke, and then the bottom part of the radius got forced up into it. Probably our patient fell, caught themselves on their wrist probably the inside of the hand near the thumb, and pushed up and forced that broken part of the radius up into the top of it. So you see there's not really any break. It doesn't look like a break, but when we look a little more closely, you see this kind of bulge of the bone out here and out here. That's where our broken part of the bone went up and into it. Again, look at our patient, the age of our patient, those two little epiphyseal plates right there. Older than the last one, I would say, I don't know, 12, 13. And then our last of our radiographs, you guys are going to be such excellent radiologists by the time you're done here. That nice twisting pattern of the bone as it breaks, that's definitely a spiral fracture. So your patient fell down, went boom. Now you need to treat them and take care of that fracture. Realigning a fracture, putting it back into its proper position, is called reducing a fracture. This is putting the ends of the broken bone back together. Usually a closed fracture won't require a lot of surgery. Now, if you have, say, a comminuted fracture, or if you have that impacted fracture that we looked at, you're absolutely going to have to go in and surgically fix that. For an open fracture, where you've got bone sticking out of the body, you definitely need to go in for surgery, both to realign that bone and get it back into the body, but also to look at all the soft tissue around that fracture and see how badly it was damaged as well. For healing, you'll use some kind of immobilization. You want to immobilize the bone on each end of the joint. So let's say you break your arm, you break your radius. You would have a cast that covers both the wrist and the elbow so that neither of those joints can move, so that neither of those bones can move. You may use traction. This would be something like an external fixator. If you've ever seen one of those with the pins coming out to hold the bones in place. That would be if you, especially if you have a lot of little pieces that need to be held in place in your bone. Look at some metabolic diseases of the bone. Osteoporosis occurs when you are not making enough new bone to keep up with old bone that's being removed. And usually when we talk about osteoporosis, the first thing that my students go to is old ladies. That's who gets osteoporosis. Grandma with her weak back and her bad hips. And that is true. You do tend to see osteoporosis primarily in older women, but you can see osteoporosis in anybody. Anybody can develop this. Now, yes, white and Asian women past menopause are at the highest risk of osteoporosis. Why women? That's because estrogen provides a protective factor for your bones. It helps to keep your bones nice and strong. And if you don't have that estrogen, you're more likely to leach calcium out of your bones. Osteopenia is not quite osteoporosis, it's early thinning of the bones. This is a sign that you need to start working to prevent osteoporosis. So how do you know if your patient has osteoporosis? Usually lots of stuff associated with height. Their height will start to shrink because you see compression fractures in the vertebrae. They'll have kind of a stooped, bent over posture. Very easy bone fractures that take a really long time to heal and then that break again very easily. And back pain, usually in the lower back. What puts you at risk for having osteoporosis? Like I said, being female, because of that contribution of estrogen to the protection of the bones. If you have a small frame, smoking, heavy alcohol consumption, those don't help anything. Inactivity is maybe the biggest one that you can prevent when it comes to osteoporosis. And then if you go through menopause early, if you have family history, osteoporosis does tend to have a genetic link to it. Okay, so osteoporosis is in my family. I don't want it. How do I prevent it? You prevent it by making sure that you have plenty of calcium and phosphorus and vitamin D. Remember when we talked about vitamin D when we talked about the skin? Right? Vitamin D is your little sunshine vitamin. You get it by going out to the sun. Vitamin D helps you absorb calcium and phosphorus from your intestine. You have to have the vitamin D in order to get that calcium and phosphorus into your blood. If you don't have vitamin D, It doesn't matter how many gallons of milk you're drinking a day, you won't have as much calcium in your blood. I said inactivity is probably the most controllable, preventable risk factor. Weight-bearing exercise is maybe the best prevention for osteoporosis. So not just getting out and going for a run or going for a walk, but actually picking up weights, lifting heavy things. When you do weight-bearing exercise, that drives calcium into your bones and strengthens your bones. DEXA scans are used to measure bone density in the lumbar vertebrae, and usually you start those around 45, 50 or so, and that will keep track of the density of your bones and tell you if you have osteopenia and if you need to start working to prevent osteoporosis. So you can see in these pictures the difference between nice normal bone and bone with osteoporosis, especially I really like this one here. You can see all the little spots and holes in that normal bone to the left, but look at how very, very thin the walls in between those little holes are in the bone there. That is very fragile, very brittle bone. Rickets is also called osteomalacia. You guys all watched the rickets video yesterday, hopefully. Our suffix here, malacia, means abnormal softening. If you remember, the opposite of this was sclerosis, which means something that's hard. So osteomalacia is softening of the bone, also commonly called rickets. This is an old disease. This is tale as old as time. Usually when you see osteomalacia, this is due to a chronic vitamin D deficiency. Like I said earlier, vitamin D helps to absorb calcium and phosphorus. If you don't have vitamin D, you won't get your calcium and phosphorus. Though you can see rickets in other forms. The video that we watched, it was not so much that the kids didn't have vitamin D, it was that they didn't have any calcium in their diet because they were eating nothing but rice. We're starting to see rickets come back, interestingly enough. This used to be a disease of a disease of Victorian era. You saw it a lot then. It's starting to make a comeback now, mostly because nobody's outside under the sun. You see it in little kids a lot. They're inside all day, sitting in front of the Nintendo or the Xbox or the whatever, making TikTok videos. And they're not outside getting vitamin D, so they're not absorbing calcium, so you're seeing a lot of issues with the bones. Signs that you'll see of rickets, usually you see it in little kids, so you'll see they're just not growing very fast, and their wrists and their ankles are starting to get really thick because the epiphyseal plates are working really, really hard to try and make bone. You'll see muscle and joint pain. The legs will get very bowed. I mean, little babies usually have kind of bowed legs to begin with, but these will be pretty bad. This can be caused by diet. Your patient is not getting anything with any vitamin D in it, or your patient is not eating any calcium or phosphorus, though there are other things that can contribute to the possibility of developing rickets. Celiac disease and cystic fibrosis interact with the way that you absorb nutrients out of the intestines. And then kidney disease, you might have a patient who's losing a lot of calcium out of their urine. That would increase your risk of developing rickets. And then you see this in infants who are exclusively breastfed past 6 months. Up to 6 months, that baby should be getting nothing but breast milk. After 6 months, mom is not able to make quite as much nutrients as they need to feed that baby, so start supplementing other food. But past 6 months, if you're just nothing but breast milk, that's not going to be enough for that child. And children who are vegan fed, it can be very hard to keep that balance of proper nutrients. If the rickets is caused by diet, if it's not something that's caused by celiac disease or cystic fibrosis, usually your outcome is very good if you catch the rickets early. And you saw that in some of the kids in the video that you watched. Some of them, their bones were a little bowed, but they said that, if we give the child calcium and we counsel the parents on a good diet for the child, that should be okay. If this is more prolonged, if the child has had rickets for years. You saw some of the kids in the video were like 17, 18. I think there was one who was 20 something. Then that's when you're talking about surgery, going in and breaking the bone and realigning it so that it grows straight. And surgery is usually pretty successful, but you saw in some of those before and after, sometimes you don't get perfectly straight legs. Some of the before and after still had a little bit of a bow to the leg. Some of those kids had to have multiple surgeries to have their legs straightened. So these are kind of your classic signs of rickets. In particular, you can see like the big bowed curved legs. The femur right here, this should not be curved like that. That's bad. Paget's disease is also called osteitis deformans. This you tend to see as your patients get older. You see it more, I think, in men. You just get this overgrowth of the bone, specifically at the end of the bone. It gets very thick. Usually you see this in the axial skeleton. You see it a lot with vertebrae. Cancer of the bone is not uncommon. And osteogenic sarcoma occurs usually in the growth region around the epiphyseal plate of a bone. So if it's happening in the epiphyseal plate, we know that this is going to happen in a teenager or a child, because you guys are all adults, you don't have an epiphyseal plate anymore. Often this will require amputation of the limb to save the rest of the body because this tumor spreads very quickly. Chondrosarcoma is a tumor of the cartilage that you also often see in younger kids around the growth plate. This also requires amputation, unfortunately, because if you don't remove that limb, that cancer spreads very, very fast. Signs that your patient has a bone tumor: obviously pain in the bone, very easy fractures that take a long time to heal and then break again very easily. And then if you draw blood, they should have really high levels of calcium and phosphate in their blood. Arthritis is inflammation of a joint. There are lots of different types of arthritis. We're going to look at two. The type that you usually think of when you think of like grandma and her arthritis is osteoarthritis. Osteo refers to bone, and then arthritis or arthro to a joint. So this is inflammation of both the bone and the joint. Here's our nice, normal, healthy joint up here. And then you can see as our patient progresses into osteoarthritis, the cartilage on either end of the bone starts to wear away. And then this leads to inflammation of the synovial membrane. And then eventually you get bone rubbing on bone. And that's where the pain of arthritis comes from. Once you get to this degeneration of the cartilage here, that can't really be replaced. Once the cartilage has rubbed off of the end of your bone, you're kind of done. So treatment for this will involve pain medication, anti-inflammatory medication, physical therapy to make sure that you're using that joint as properly and as safely as possible and strengthening the muscles around that joint. Rheumatoid arthritis is also arthritis, a very different type of arthritis though. This is not your typical wear and tear of the joint. This is one of our autoimmune diseases. We have a lot of autoimmune diseases that we look at in this class. So this is inflammation of all the joints. Systemic inflammation, which if you remember means the whole body, not just one place. You see in rheumatoid arthritis, the synovial membrane is actually the thing that your body attacks, and it gets very big and swollen. And when it gets swollen, it starts to push the bones of the joint out of place. And eventually those bones will ankylose, they'll fuse together out of place. And you'll see these really, really misshapen bones, and usually in the hands and the feet. There is no reversing rheumatoid arthritis. There are medications that will suppress the immune system and keep it from attacking the joints. A lot of physical therapy that you'll use to make sure that you're using the joints properly, but not a lot that will reverse it. So you can see the way that the bones have been pushed out of alignment here in this patient's hands, especially at the knuckles here. She's not holding her fingers like that. That's permanent misshapen because of the rheumatoid arthritis. Gout is a buildup of uric acid in joints in the body. Uric acid is made from protein. When you break down protein in your diet, you produce uric acid as a byproduct, and it's usually just flushed out by the kidneys. But if you have really high levels of uric acid in your blood, it will build up in your joints, and then it causes a lot of pain. And the place where it most often builds up is that first joint of the big toe. That's where you tend to see buildup of uric acid crystals. Gout comes on really, really suddenly. You get this sudden attack of gout, usually at night, and it usually creeps up within like 10 to 15 minutes. It can be very, very painful. There is medication that you can take that will reduce your chances of having gout. Either it keeps you from making uric acid, or it increases the amount of uric acid that your kidneys flush out. Once you have one episode of gout, you're very likely to have gout again. And it's recommended that if you have a lot of issues with gout, that you go on a low protein diet to address those high uric acid levels in your blood. So when we talk about all of our joints, arthroscopy is the technique of looking into a joint, usually to see what's going on, often to do surgery. So we have here our patient's knee. Let's pretend we're doing a repair of their ACL, their anterior collateral ligament. You would go in with an arthroscope that has lots of tiny little tools in it right here, and those tools would help you fix the ligament that's torn in that knee. If you replace or reconstruct a joint, that's called arthroplasty. So you hear a lot of the times about someone getting like a hip or a knee replacement. That would be an example of an arthroplasty. And then fusing a joint together is called arthrodesis. You see this sometimes in the lumbar vertebrae. If they are very badly damaged, you might fuse those vertebrae together. Sometimes you see this in the ankle, A-N-K-L-E, as well. If you have a patient who has maybe really bad ankle pain, you would go in and fuse the bones of the ankle to keep them from moving. You see some issues with the spine. Ankylosing spondylitis is a disease of the spine that you usually see in men, though the only person I know who has ankylosing spondylitis is a woman. Ankylosing spondylitis is another one of our autoimmune diseases. In ankylosing spondylitis, you see inflammation of the joints that leads to buildup of calcium in the front of the spine. That eventually causes the bones of the vertebrae to fuse into one big bone. They call it bamboo spine, so it looks a little bit like bamboo. This usually starts towards the bottom of the vertebrae and progresses upward. It's very, very painful, incredibly painful. There's not really any good treatment or cure for it. Your patient will be on some pretty heavy-duty anti-inflammatory medications and some medications that will suppress the immune system. Ultimately, your patient will lose their posture because of this fusing of the spine. They'll have this hunched forward, rolled forward posture because all of their vertebrae have fused together. Spondylolisthesis is fun to say 5 times fast. This occurs when you have a vertebrae that slides forward over another one, usually because of breakdown of the little bones surrounding the vertebrae. So we can see we got a little break in our bone right here, and that caused this vertebral body to slide forward. And now we've got this big gap back here. You tend to see it towards the bottom of the spine. Also very painful. This will require surgery to fix. Herniated disc or a ruptured disc is not uncommon. This happens when the center of the intervertebral disc starts to poke its way into the spinal column. You usually see this in the lower back or in the neck. Usually you see this from straining. An injury to the back, usually heavy lifting. So if we look at our picture here, there are 2 parts to the disc, the intervertebral disc that sits in your back. This center part here is called the nucleus pulposus. It's kind of a jelly-like cushion that helps to absorb shock in between the vertebrae. And then you have this fibrous tunic, this really tough outer ring that wraps around the nucleus pulposus and holds it in one piece. If you herniate a disc or rupture a disc, that usually happens towards the back right here. And when that happens, this nucleus pulposus can then get out and squeeze this little spinal nerve right here. And that hurts a lot. You can see in our, I think it's an MRI here, here's our nice normal vertebral body. This is what they should look like. And then down here, we've got our vertebral body, but the little pale part here that you see up here is gone because it's all out here pushing against the spine. We see this particularly bad here, this bulging in the back of the spine. You may have to go in and remove those discs. You may be able to surgically fix them, but that will definitely need some surgery. The spine should normally have some curve to it. That's what helps it support the weight of your head and the weight of your back and your body. You should have a little bit of curve to the cervical vertebrae, a curve out to the thoracic vertebrae, and then a curve in the lumbar vertebrae, kind of like that. You can get excessive or exaggerated curves, though, of the spine that affect the way your patient moves. So kyphosis, what we have here, is an excessive curve in the thorax, what we will call sometimes a hunchback. Sometimes this is very noticeable. Sometimes it's only noticeable when your patient bends over and you see their shoulders really sticking up. Lordosis is kind of the opposite of that. That's an increased curve in the lower back to give you kind of a sway back. And then your spine should normally travel straight down the back, straighter than the line that I drew. If the spine deviates out like this does to the left or to the right, that's called scoliosis. Most of these can be addressed with back braces that can help to bring the spine into proper alignment. If that doesn't work, you might need surgery, but sometimes even that will not straighten out the spine like it should be. So that is that for the skeletal system. Look through the term words on here, see if there are any that you're not familiar with. They should be very, very helpful for the test. And as always, if you have any questions or if you would like to go over any topics or double check anything, please stop by office hours. I would love to see you there.